Today, I will discuss the topic left pain, our experience. So I am working in the Calcutta Fortis Hospital. So it is one of the highest left pain volume, center volume in East India and perhaps in the India. So the basically, what is the approach of left pain intervention? Now, before selecting the patient, there are some clinical situation where we prefer left main PCI over CABG. Now, there where there is a ACS patient, STEMI or NSTEMI urgent revascularization is required. Patient with a serious comorbidity with a high surgical risk, that is a chronic lung disease, advanced age, and prior stroke, prior bypass surgery. So they are the basically candidate for whom we advise the left main PCI. Otherwise, those patients who have a low ejection fraction, long-standing diabetes, need for other concomitant cardiac surgery for whom double antiplatelet therapy cannot be continued for long duration, we prefer bypass surgery for them. Now, there are some anatomical subset also. Now, ostial left main and your shaft left main is basically a interventional domain, no doubt about that. But the problem with the left main bifurcation, particularly the true bifurcation, and with a very complex lesion with a high syntax score, we prefer bypass surgery than your PCI, if not contraindicated for bypass surgery. So this is our approach for the left main intervention. Now, there is a very interesting shift of classification of the left main bifurcation. Basically, till now we are actually using Medina classification, but now the paradigm is shifting. Now we are not using the term Medina classification in the left main. We are actually uttering whether it's a simple bifurcation or a complex bifurcation. So this is a very important in shifting the terminology and regarding our decision making in left main intervention. Now, what is the simple bifurcation? Yes, the circumflex ostium is involved, but the length of the lesion is less than 10 millimeter and diameter stenosis is between 50 to 70%. So this is a simple bifurcation. And the complex bifurcation, the lesion length is more than 10 millimeters and the diameter stenosis is more than 70%. Along with there is other criteria like your severe calcification, bifurcation angle, if it's more less than 45 or more than 70. So these are basically other complex
Hello, check 1 2.
where we can
Hello,
decide
hello,
whether we are
hello.
dealing with
Check,
a
check,
simple left main
check,
bifurcation
check.
or a complex left main bifurcation. Yes, if it is simple left
Better
main
no?
bifurcation,
Check,
it's a stepwise provisional
check,
stenting. It is
check,
the choice. It is it is basically the your treatment of
one,
choice
check,
and
one, check,
endorsed by your
check, one,
EBC
check,
group.
check,
And basically, I will not say it's a
check, one,
technique.
check.
Basically, it's a philosophy, because the philosophy behind this
Hello,
stepwise
hello,
provisional
hello,
stenting is that
hello,
you just secure the main vessel
hello.
first, save the patient,
Check.
save the main vessel first, then see what we can do with the side branch, whether we leave it, whether we can do a DB, whether do your second stenting. So that is we will get time, but I have to secure the main vessel first.
Check,
So this is the, I think, the philosophy behind this your
one,
stepwise provisional stenting.
check.
Now, this is the steps of provisional stenting till today morning. Different experienced operator have explained.
Check one, check.
There's nothing new to say, add on, but I just want to highlight one point. The essence of the stepwise provisional stenting is a POT, because it is not only the ease of wearing of the side branch,
One, check,
scaffold of the main
one.
in the side branch and give a ostial scaffolding. So this is very important. So if you do a final kissing or side branch dilatation after in the side branch, then there is a layer of your metal at that your side branch ostium, and you can perform a typical T stenting without a significant overlapping of the metal high metal burden in the carina. So this is the essence of POT. POT is very important. It's basically the key factor in doing a stepwise your professional stenting. Note, I will just show my 2 or 3 cases. So this is a 56-year-old recent RCA primary angioplasty, and there is some chest pain and LED showing
I'm muted now?
disease,
Muted now?
you can
Muted now?
appreciate the disease in the LAD, and the disease almost started from the left main and extending in the LAD. Now, this is the classically described the spiky carina, the IVAS description of the spiky carina. So you cannot place the stent, though the left main ostium, left main, distal left main is not very significantly diseased, but in such spiky carina where this is present, particularly in angiogram or in the IVAS, you cannot put the stent in the LAD ostium. They will severe, they will pinching and will be in trouble. So you have to put the stent from the left main to LAD and see what what we can do for the circumflex. So the 7 French catheter, femoral approach, scoring bed preparation with a scoring balloon, 2 stent, then 2 overlapping stents, and after this stenting, the pot, and you can now assess the side branch ostium. So this is the after pot and post dilation of the main stent. This is the situation of the side branch. There is a significant narrowing of the side branch ostium. Now, what to do? Whether to do your second stent or just do a kissing. So, according to the EBC, you just did a good dilatation and kiss. Then see what is happening. So, we actually followed the steps. We did a final kissing balloon dilatation. So our protocol is to take a 1:1 vessel size non-compliant balloon and give a sequential high dilatation of the both ostium, both the LAD ostium, both the circumflex ostium, and then to a moderate final kissing balloon dilatation with the same balloon. Now after the moderate dilatation, this was the result. So caudal view, the result is quite satisfactory, and probably it was a carina shift rather than plaque shift. We did a IVAS in the circumflex. This is the IVAS run. I am not going in the long run of the IVAS, but in the circumflex, we didn't found any significant or flap or like complication. So we decided to leave the patient, and the patient, this is a IVAS, your measurements, and we leave the patient after the final pot. And this was the angiogram after 1 year follow-up. So this is the 1 year follow-up, and this is the, I think this is the, yes, this is the 1 year follow-up angiogram, and patient is doing perfectly well, no complication, no issue. So this is the classical description how stepwise provisional approach works. Basically, don't jump to a second stent, because always the 2-stent strategy in a left main bifurcation has a worst outcome than a single stent strategy. So this is the basic take home. Now this is a second case. So now what is the problem of your this provisional stenting? Now this is a 70 years old gentleman, diabetic ACS. Basically, we have a 55-year-old 55% LV ejection fraction, mild hypokinesia, and this is the angiogram. So basically, this is a left main disease. It's a complex left main disease. The circumflex ostium is a significant disease, and the length of the lesion definitely more than 10 millimeter. And also LAD proximal part is also involved. RC is non-dominant. Now what to do? Now what to do? Strategy. So this is basically left main trifurcation, but I am not going to the trifurcation. We will keep the ramus only flowing. We will treat the main vessel to the LAD and the circumflex. Now, in this case, from the very beginning, I think 2-stent strategy is very appropriate, because considering the large circumflex with a significant longer lesion, so securing of the second branch is very important to me. And we will can use the crush technique, decay crush, mini crush, and nano crush. Now, in this scenario, I just want to highlight a novel technique. It is a basically modification of the mini crush technique, nano crush. It was actually published from our Fortis team. Dr. Roy is our main proctor at that time, and we have published the data of the nano crush. Is a very simple technique. I will just describe few steps of the nano crush in this case. So after proper pre-dilatation, so we put the stent in the side branch and dilate and keep a NC balloon in the main vessel, one size smaller than the distal reference diameter of the first branch. Now dilate now inflating the main vessel balloon and pull the side branch so that it will not miss the ostium and there will be no significant protrusion in the of the side branch stents in the main vessel. So this is the essence. So one way you will not missing the ostium, and number two, there is not too much of protrusion. Then after inflation of the your stent, we flared the stent with the stent balloon after few millimeter pulling, then crushing with the main vessel branch, and then first kissing. So this is the stepwise description of the nano crush, and then put the stent from in the main vessel from the left main to LAD, then recrossing, recrossing, wearing, final kissing, and final pot. So this is the in nutshell the nano crush technique which we are actually practicing in our hospital, and gradually this actually evidence with the nano crush is increasing, and side branch wearing and long-term results are very satisfactory with this technique. So this is the final result. My third case, it is a provisional, it is a inferior MI. I did the your RCA primary, very straightforward. Then after a few days, I took the patient for the left main. So left main, you can see, is a very nasty disease, diffuse left main involvement with a very significant disease. Circumflex, we cannot assess what is the ostium of the circumflex, but to the angiogram, the circumflex ostium was not significantly diseased. So I planned for a single stent strategy. But the problem is that after this ballooning and all this, the patient having started slow flow, I put the stent from the LAD, LM ostium to LAD and secured the main vessel. Patient was a little bit better. But what happened to the circumflex, you see, is a very nasty looking circumflex. It's a almost actually TIMI1 or TIMI1 flow. I tried with the balloon. This is a pot, and I tried with the balloon to open the strut, and kissing with balloon. There is some flow, but still not satisfactory result. Then after the final kissing balloon, this is the result. I cannot actually leave the patient with such result. Then I have to put the stent here, and tap technique is the best technique, I think, to in such cases. Pull-out is very cumbersome. Tap is very straightforward. Put a stent and keep the and just do a final kissing with the stent balloon, and keeping a NC balloon in the main branch. So this is the tap, and this was the final result. And patient is doing well. Is a IVAS. I am not going in the detail for the time constraint. So this is a spot, and this is a 1 year follow-up of the patient. So the patient is doing well. I will finish my presentation. Just last case is very interesting. Sometimes we actually landed up with such problem. I did a primary PCI of the circumflex just 15 days back, and plan to do the LAD. So this is you can see the circumflex stent is almost near the ostium, and there's a LAD. There's a significant lesion. In the second sitting, I just want to fix the LAD. It's basically a straightforward case, no issue. But problem was that after dilating and the putting stent, there is some respiratory movement which occurs sometimes, and I could not properly place the stent. And what I saw after placing the stent, so the main vessel stent has been pulled some in the left main, few millimeters. It is in the left main. So this is you can appreciate, and the circumference stent, which is not exactly distal to the circumference ostium, it was perhaps in the left main also, and there's a crushing of the left main circumference stent. You can appreciate there's a small crush segment. So what to do after whether it is leave it alone, place another stent or something else? Yes, we cannot leave this stent, hanging stent in the left main. It will lead to complication. We have to do something. We can place a stent, but giving the 2 stent in the left main and 2 layer in the just carina is very bad thing to do, I think. So what I did with the help of the stent V's, I just put precisely 6 millimeter balloon, 4 millimeters balloon, and just like pot, I did a pot here. So this is a pot in the proximal part of the stent, and rewiring done. Rewiring was a little bit difficult due to the obtuse angle of the circumflex. And after this rewiring, I just do a simple kissing balloon inflation, similar principle, 1:1 sizing of the balloon, initial sequential high pressure dilatation of the both the branches, and then final kissing with the moderate balloon. And this 10 boost is very helpful in actually placing such complicated cases where you can exactly place your balloons. So this is so we finish the case, and the patient is doing, though almost only 2 to 3 months have been done, the patient is doing well so far. And this is our experience of the left main angioplasty. And we have seen in the bifurcation lesion, two-sense strategy is always they have a significant lesion, significant messy in terms of target vessel failure, myocardial infarction, and the patient with a low ejection fraction and the higher syntax score less than more than 32, they are basically bad subset, and they should not be do routine two-sense strategy. Two-sense strategy should be done in a with a low syntax score is a less complex cases. So it is our opinion and our study. And this study, perhaps India is the first study of the single center left main series is in the published in 2016. So to conclude my session, my presentation, left main intervention is always challenging. Left main ostial and the isolated shaft disease are straightforward. It is not a basically any problem. You can do with the help of a imaging, you can do straightforward these cases, but distal left main bifurcation, provisional approach should be the choice, except the complex bifurcation where you can, every chance that you can lose that side branch, and side branch wearing and stenting is very difficult, then you have to fix the side branch first. So this is very important in case of doing the left main bifurcation. Proper bed preparation is very important. You can use your cutting balloon, scoring balloon, IVL, rota, but you need to do a good bed preparation. Without doing bed preparation, you should not do left main intervention because the result can be catastrophic. And imaging is necessary. Yes, today morning we show we were shown that IVAS definitely reduce the mortality, but in our country, even Bangladesh and India, IVAS is not possible for the every cases because the financial constraint, government policy like that. But in this case, you have to mind the finesse law. If you can assess the LAD and the LCX and you can apply the finesse law, you will get the size of the LM. So this is also an approach, and you should take during the left main intervention where you are not doing the imaging or not able to do the imaging. And obviously, hemodynamic support is required when you are dealing with the left main cases with a low ejection fraction, single surviving artery like that. So in nutshell, it is the my message, take home message. Thank you very much.